What we're seeing on the street is illicitly manufactured fentanyl that's coming into the United States through Mexico, where it's either coming in powdered form, very small amounts, or increasingly pills.
Welcome to Canusa Street, a podcast at the intersection of the issues and policies between Canada and the United States. Here are your hosts, Scotty Greenwood and Chris Sands.
Welcome back to Canusa Street, everybody. I'm Scotty Greenwood with the Canadian American Business Council, and I'm joined by my good friend, Professor Chris Sands of the Woodrow Wilson Center. Hey, Chris.
Hi, Scotty. How are you?
Doing well, doing well. We have kind of a heavy topic today, but timely and important. We're going to talk about the flow of illegal drugs in and out of the United States and what it means for people and what it means for policy. And I'm really delighted that we have one of the leading experts in the United States on the topic with us. She's someone that I've known and admired for many years, Regina LaBelle. And maybe, Chris, I'll turn it over to you to introduce her properly, and then we'll get right into it.
Excellent. Well, thank you, Scotty. And I'm as excited as you are. Regina LaBelle is a very distinguished scholar and is the director of the Addiction and Public Policy Initiative at the O'Neill Institute. Now, working at the intersection of law and policy, LaBelle's work focuses on identifying policies to reduce overdoses using the law to promote access to quality addiction treatment, harm reduction, and recovery support services. She also comes to us with decades, although those of you who can't see the video know that won't make any sense. If you see her, you can't imagine she spent decades doing anything. But she brings decades of public service to her work at the O'Neill Institute. She was an appointee in the Biden-Harris administration and served as acting director of the Office of National Drug Control Policy, ONDCP, as we say here, in the executive office of the president. She was the first woman to serve in the position, and she oversaw the establishment of the Biden-Harris administration's drug policy priorities. Now, before her work in federal government, she served as legal counsel to Seattle's mayor, Greg Nichols, providing legal and policy advice to the mayor on high-profile city issues. So she's looked at this from the federal level, she's looked at this from the local level, and brings a real package of insight, which we are really excited to have. Regina, welcome.
Thanks so much for having me, Chris and Scotty. I appreciate talking about this topic.
Well, maybe I'll just kick things off here with you, Regina. And I want to start, if we could, with the North American Leaders Summit that just occurred in Mexico City, because there were bilats and trilats, as we say, meaning Canada, U.S., Canada, Mexico, U.S., bilats and trilats. The bilateral conversation with Mexico this time around focused a lot on two things: migration and the flow of fentanyl in particular. And so I wonder if you could talk about that. Is Mexico, like, how do those things go together? How are they different? People sometimes conflate the issues. And based on your many years of experience, is the drug problem across the U.S. southern border getting worse? Or are we just hearing about it more because of things like the North American Leaders Summit, because of things like fentanyl? So maybe give us a state of illegal drugs coming into the U.S. and your thoughts on that.
So, a huge issue, obviously. First of all, thanks for having me here to talk about this, Scotty. It's great to discuss it, this important issue, and the North American Leaders Summit. So I think the big picture issue here is that in the United States, we have over 100,000 overdose deaths annually. And that's a record amount. It's about 107,000 right now. That's record numbers. And there's been a lot of attention paid to overdose deaths in the United States. I started in the Obama administration in the Office of National Drug Control Policy in 2009. At that time, it was primarily prescribed opioids were driving overdose death rates. So we've gone from prescribed opioids. There are three waves of the epidemic, of the overdose epidemic. Prescribed opioids to heroin and fentanyl. We're in that wave right now. And when we look at fentanyl, I think it's important to look at, it's not about fentanyl per se. It's about the new trend of synthetic drugs, So in the past, when you think about drug trafficking and you think about Colombia, the drugs that we used to see were not synthetic. They were grown. And so that's really part of this. That's what's made this so complex and so important for Mexico, China, Canada, the United States to have these discussions about this new trend of synthetic drugs as they morph, as we see different types of drugs. So I'll stop there, and then we can go further.
Not only have you worked for President Biden, you worked for President Obama, and you're known, I would say, for being one of the key thought leaders on the concept of harm reduction. And I wonder, for people who don't work in this space, if you can talk about what does that mean? What do we mean by harm reduction? What is it as a policy focus? And then I'm going to ask you about your experience and observation of Canada's policies, particularly British Columbia, since you were right next door in Seattle, Washington, and compare that with the U.S. with respect to harm reduction in particular.
So, harm reduction has been open to a lot of interpretation over the years, but really it's grounded in two things. One is that you meet people where they're at, but you don't leave them there. Addiction is a disease, as we know. It's also a condition that can be prevented, treated, and from which people can recover. So it's important that we approach addiction with the person in mind, and not from, that we can punish the substance use disorder out of the person. But that we try to approach them from what they might need. And that means preventing trauma that can lead to later substance use disorders and getting people the help they need, which includes people with chronic conditions.
Thank you for that. As we think about the opioid crisis, which is almost a catchphrase, everybody is talking about it. A lot of people have been personally touched by someone in their family or their community, but it's now a political issue too. Where are we with the evolution? You started to talk about this previously, but where are we in is the main drug problem in the U.S. opioids? Ask it that way, or is it something else? And how are you feeling about the policy responses to confronting it?
Well, so the main drug problem in the United States is alcohol, actually.
Okay.
More people die from alcohol-related conditions than from other conditions, other drugs.
That's important to point out, and I don't think people know. Again, you're a specialist and we're generic, so that's very interesting. Anyway, keep going.
Alcohol, tobacco, there's substances that can cause harm.
Yeah.
Illegal drugs, certainly, and we've talked a little bit about fentanyl, those can create immediate harms. They can also, among those harms can be incarceration and all of the consequences that can result from incarceration. So a lot of the work that we focus on at Georgetown, as well as the work we focused on the administration, was really to make sure that we were, treating this as a public health issue. But that doesn't mean necessarily, like turning a blind eye to international crimes and drug trafficking from an international perspective. That means appropriately addressing issues on the individual level, as well as looking at it from, the counter-narcotics piece. That's an important criminal aspect of this.
One more question about this. How should policymakers think about the drug crisis? I don't think people are thinking about alcoholism actually as a drug crisis the way you just explained it. They think about illegal drugs, and when we think, some things started out as legal. So opioids are painkillers that were abused over time. Fentanyl, though, these synthetic drugs, aren't they manufactured for the purpose of getting people hooked or serving their addiction and then making money by bad guys out there? I mean, isn't that kind of what's going on?
Yeah, I mean, so there's illicitly manufactured fentanyl, which is what's driving the overdose crisis. And then there's fentanyl that's used for end of life care that's really life saving for people who have cancer. So, you can get fentanyl patches. Those are really important, drugs for people. When properly administered, can be really important for individuals. So it's important to distinguish those two. What we're seeing on the street is illicitly manufactured fentanyl that's coming into the United States. For a while, it was coming through the post, directly from China. That's not the case anymore. It's coming through Mexico. I mean, really, the cartels had quite an opportunity when China stopped shipping it to the United States. Now it's going into China, where it's either coming in powdered form, very small amounts, coming in through powdered form, or increasingly pills. The pill issue is incredibly concerning and should be of great concern for policymakers and parents too, because the pills look like they're often, counterfeit. They look like Xanax. They look like something else. And they're, a high percentage of fentanyl that are driving overdose deaths.
If I can ask you, Regina, I was thinking a little bit about this. You mentioned alcohol. With alcohol, when people are abusing alcohol because it's legal, I mean, with certain restrictions, they and their families may help them to get help. Whereas with a drug that is illegal, that illegality, the possible criminal aspect of it, may deter people from seeking help because it involves an admission of something that could get them in trouble. Marijuana is in the middle. For a long time, it was illegal. It's still, I know, still illegal federally, but we have now some data on the use of marijuana, in a legal way. What do we know about people's reaction to legalization or decriminalization when it comes to seeking help and creating support structures for people to get back from addiction? Has that been a benefit? Because I think that debate is still being hotly held in the U.S., and I know Canada has decriminalized nationwide.
That's a great question, and I wish I had more research on that, but I don't. Are people seeking? I mean, the fact is that about 13% of Americans who need treatment get it. And that's pretty much across the board. So even for alcohol use disorder, most people aren't getting treatment, for a number of reasons. And there is stigma. The criminal sanctions that are attached to illegal drug use it's a very important piece of this, and it does prevent people from getting treatment. But what we've done in this country is we don't see it, even though we talk a lot about the fact that this is a disease of the brain that's been around since the 80s or late 80s, early 90s. We still don't have the type of infrastructure. Like if you went into your doctor and you told your doctor, Doc, I'm drinking 5 drinks a night, the doctor might tell you should slow down. You tell the doctor I'm doing cocaine, doctor might say, probably not a good idea. But most medical professionals, healthcare providers, don't know how to treat addiction, right. And don't recognize it. It is not taught in medical schools. And so we need this wholesale change. I'm just so enthusiastic about what we're seeing. I think we're turning the corner on this issue, but we're certainly not there yet with 13% of people getting treatment.
Just as a quick follow-up, I want to ask about how we build structures for treatment. And I know they're not a perfect analogy, but we went to the alcohol producers and said there needs to be support for Alcoholics Anonymous and thinking about programs and maybe even labels saying if you should get help. We went to tobacco and we put labels on things and we got them involved in trying to help with addiction, things like Nicorette and all of that. We even went to the casinos and said, people with an addictive personality, you're taking advantage of them. You have to have a proactive program, support NGOs that are going to get people out of their addiction. I wonder in a case like this, is that the public good trade-off for allowing some regulation that you then turn to industry and say, the taxpayer isn't going to pay for this, you're going to pay for this from the money that you're making on people who using it responsibly are fine, but we really feel that you can't, because on marijuana, we don't do that. And there are a lot of new companies getting in the marijuana business, and we're not putting an obligation on them to fund addiction treatment. But maybe that's the wrong model, and you know this better than I do. So let me...
Great question. Lots there. I also direct at Georgetown a program on addiction policy, and everything you just touched on are classes that we cover. So I could talk about it for hours, but I won't. But I think what you're talking about, I mean, first of all, remember, we sued the tobacco industry. You know, the attorneys general around the country sued. They didn't voluntarily say, we'll stop creating these addictive products. They were taken to task for what they were doing, and they had to pay. Yeah. Now, the majority of that funding didn't go to pay for prevention or healthcare. It went in some states for potholes. But the point you're raising about excise taxes going to pay for the externalities, going to pay for those social costs, the social costs of those products is really important. So tobacco industry, we've been successful in decreasing tobacco use in this country, particularly and importantly, youth tobacco use. We have seen somewhat of a decrease in binge drinking in youth. We saw a little bit of an uptick this past year in youth alcohol use. But the alcohol industry, the taxes for the alcohol industry have been reduced. There hasn't been an increase in the gambling tax in years. And one of my ponies that I'd like to ride on is this issue of there is no federal strategy on gambling for gambling disorder. Yet we're seeing this huge increase in gambling issues in this country and legalized gambling. So we're going to wait, obviously, until it becomes a crisis, and then we'll say we need a gambling.
It's the American way.
But in other countries, the UK has better plans for this, and as does Australia. But everything you raised about the tax pieces going to pay for the externalities that are caused is really an important piece of the policy puzzle.
Yep, and not one that Canada has solved necessarily. Over to you, Scotty.
Well, and each of these topics, as Regina says, could be an entire class in and of itself. I think probably we should draw a distinction between cannabis and other drugs. And we didn't really unpack that in your question, but let me, Regina, a few moments ago, you said you think we're rounding the corner and that you're optimistic. What do you mean? What's happening and what makes you optimistic? Because this is a very difficult subject, and I'm grateful for people like you that are working on it all the time, because it's hard. It takes its toll when you think about all the people that are dying or their lives are just really negatively affected by these disorders and by illegal and legal drugs. So why are you optimistic? Why are we turning a corner? What do you mean by that?
Yeah. So, like you all, I've been in the policy space for a long time, and I wouldn't stay in this if I weren't optimistic, particularly about, such a really harrowing issue. I mean, I get calls and I keep in front of me on my side of my desk, some of the pictures of people that I know who have passed away from overdose deaths.
Yeah.
To remember why we're here. I'm optimistic because I'll give you an example. So I was on the transition team for the Biden-Harris administration, and I helped out in the campaign as well. And during the campaign, we put together, this plan for what needed to be done to address the issue. And one of them was, methadone has been around for a while. It's a generic drug. Methadone is an incredibly effective medication that reduces overdose deaths, that helps people enter recovery, reduces recidivism. It's a good medicine, but it's been stigmatized, and also there's a lot of shackles around it. And it prevents people. It's almost perceived of as a punishment to get methadone. You have to go every day, even if you have a job, you have to go every day to the methadone clinic until we figure out you're stable. And all that is done in these rules. And so step by step, the new rules that the Biden administration put out for public comment a couple of months ago I was just going over them with colleagues. They're quite remarkable. And they could, once they are implemented, they can go a long way to making change, to making methadone accessible, and not only accessible, but a medication that isn't as stigmatized, that people can get and, not feel ashamed and not have to whisper about being on methadone to treat their condition. I mean, what we want to do is, again, we want to prevent these conditions from ever happening, but we also want to make it so that if you have this condition and you're seeking treatment and you're in recovery, you don't have to whisper about it. You can say, this is a fact and this is who I am.
Is there a jurisdiction that's getting it right in the world?
In the world, I mean, every country has some of its own unique qualities. Certainly, Portugal is always considered, a good example of how they reduced overdose deaths. But, remember, like Canada, we have, Portugal has this very robust public health system. And there's a lot of trade-offs in the American system that aren't present in these other countries. So, I think we can look to a lot of European models for how they're handling it. They also have, because of the social safety nets that they have, less childhood poverty that often causes trauma that leads to later substance use disorder as well. So I think looking towards countries that have that model of the social safety net and then robust treatment is another way. No country, I don't think, has really gotten rid of all the stigma. That's certainly not. The United States has actually done, is in the forefront of supporting people in recovery. And the recovery movement is certainly greater in the United States than a lot of other countries.
And what about Canada, U.S., Mexico? Like, can you compare and contrast our North American neighborhood?
So, I've been in meetings before with our Canadian brethren about, to discuss issues with law enforcement. I think that they definitely, Canada has taken is much more forward-leaning in public health. And there's the public health partnerships with law enforcement. Certainly in British Columbia, they have the overdose prevention sites, often called safe consumption sites, which they've had for decades. When I was in Seattle, we went to see them once. So I think Canada is probably more forward-leaning on the public health side. I think on Mexico, they didn't have high rates of illegal drug use. I think they're starting to see it now. And I'm not sure, I don't think their treatment system is as robust as it could be. That's part of the partnerships that we were working on when I was in the Biden administration, is how to provide them with more, and with Canada, through Canada too, providing them with more information on cutting edge evidence-based treatment programs. That's something National Institute on Drug Abuse has done with Mexico as well. And then on the illegal drug flow, for decades, Mexico would always say, "Look, we wouldn't have an illegal drug problem if you guys didn't consume it." And I think that we were able to show them. These are all the things that we're doing. These are all the investments we're making to reduce substance use disorders in our country. And so I think that went a long way to stop some of the finger pointing and to work on some more productive means to, reduce the flow, but also reduce the demand.
Regina, this is all very useful, and we're going to take a quick break. And when we come back, I want to talk a little bit more about international cooperation on countering addictive behaviors on a range of things, but especially focusing on fentanyl and some of these synthetic drugs. But have to pay some bills, so we'll be right back.
The Wilson Center's Canada Institute is a proud co-producer of the Canusa Street podcast. For more insights and analysis from the world's leading think tank on Canada-U.S. relations, please visit us on the web at www.wilsoncenter.org.
Welcome back to Canusa Street, everybody. I'm Scotty Greenwood with Canadian American Business Council, joined by the best co-host in the podcasting world, Chris Sands of Wilson. We're talking to our friend Regina LaBelle. She's a distinguished scholar and the director of Addiction and Public Policy Initiative at the O'Neill Institute, which is at Georgetown University, right, Regina? That's where O'Neill is? Is it named for Tip O'Neill?
No, it's named for an alumnus of the Law Center who has graciously donated a lot of funds to keep us going.
Okay, fantastic. And for those of you just kind of tuning in now, Regina has an amazing background at several White Houses, mayor's office, think tanks, advocacy. So we're really happy to continue the conversation. And Chris, you were about to ask another question right before we left.
Well, yes, thanks, Scotty. And what I wanted to ask about was the kind of taking this a bit bigger. You before the break, you were talking about Mexico, and we had this period with Colombia as well, saying, well, you know, you're driving the problem with demand. Our supply shouldn't be the focus, it should be the demand focus. And that you've countered that a little bit. But it often feels like organized crime, the people who traffic in anything bad, take advantage of governments that can't cooperate, that are unable to coordinate or share information. They thrive on governments not working as effective as they could. And I wonder, have we learned anything about ways to foster international cooperation among law enforcement, among medical professionals and others that could give us a sort of a sign of hope going forward, that this won't always be that negative crime story, but it could be a positive story about how Canada, the U.S., maybe for starters, we like each other, but also going abroad, we work on this together as a international community.
Yeah, I think the administration was trying to take the drug issue out of the not being the central issue that we had to deal with. Certainly that was Colombia. We had a new agreement with Colombia when I was there, signed with the last Colombian president, and then also with Mexico. The corruption and capacity building that's needed. I think if you look at, the people who do the on the ground work, the day-to-day work, there's a lot of cooperation, the career staffers. As you well know, that often gets disrupted by political changes and political chatter that takes over a lot of that discussion. Now, it hasn't been without its bumps with Mexico, certainly. And I'm totally understating when I say bumps. It's been, I think it's been a very fraught discussion. So as with anything, you find what you can agree on. And I think that's what they're trying to work on, and to make sure that we're not just talking, they're not just pointing their finger at us and saying, not only is your demand out of control, but you're giving us all your guns, and having some type of agreement, something where we can find out, okay, then let's look at, what we can do in terms of agreements about pill presses, agreements about precursor chemicals. Are there things that we can meet in the middle on? Because the other, some of the bigger dialogue tends to be very fraught.
What is an agreement on a pill press? What does that mean? What is a pill press? What does an agreement mean?
I mean, one of the issues is to make sure that we're all kind of on the same page when it comes to our laws. And, pill presses, as of a couple months ago, I don't know if this has been changed, were still legal in Mexico. So that can help. And even if they are illegal, the cartels will figure out how to get their hands on them. So making sure that we're on the same page in terms of those types of tools that can help drive these innovative ways to get, you're never going to get ahead of the cartels, but you can at least, try to disrupt the markets some, so that to keep them in line.
George Grayson, who used to teach at William and Mary, once said something that stuck with me about the debates about drugs with Latin America, that you should never let policemen run your foreign policy, because they do tend to take a zero crime approach. It's very cut and dried, and it really makes it hard to build cooperation. I wonder, now that we've had the COVID-19 experience, what do you think about public health people being involved in foreign policy? On COVID, we talked a lot about vaccines and best practice, and we tried to share information. It does seem that we're better, doctors talking to doctors, than necessarily cops talking to cops. Do you think that medicalizing this or putting public health at the forefront is a good step to build partnerships, or do you think it has a downside I might be missing?
No, I think that's essential. And, that's why we started the National Institute on Drug Abuse, that like what research do we have that we could share? Mm-hmm. It's the National Institute on Drug Abuse is one of the, in the National Institutes for Health in the United States, is one of the most well-financed drug policy, addiction policy researchers in the world. And we have a lot of items that we can share with them. So, Dr. Rahul Gupta is the head of the Office of National Drug Control Policy. First time they've had an MD. And wow. I think that changes the dialogue. Because often when I first started in the Obama administration, we were always like put in the national security lane, which meant public safety, not public health. And so during the Obama years, we spent a lot of time like opening that aperture up, making sure that we were getting people to work for us, not just, people with law enforcement backgrounds, but also people with public health backgrounds. And, I'm a lawyer. So I always tried to bring people in who would complement me from a public health standpoint to show me what I didn't know, which was a lot. And so having public health in the room is a really important part of the dialogue.
Notice that I didn't ask you about lawyers running our foreign policy. That cow is out of the barn. So over to you, Scotty.
Regina, where do you come down on some of these new drugs? You've talked about how there can be good beneficial uses for certain drugs, and then when they're abused, they can be catastrophic. So there's a lot of discussion these days on psychedelics and their potential use for mental health. It's something that people have a lot of stereotypes about, but I wonder where you come down on the emerging interest that seems to be out there on psychedelics.
Yeah, so I have two pieces about that. It's like, where does the science lead, and do we have things in the way of making sure the science is leading? And that's science not led by politics. It should be like the real science, which is not my bailiwick.
Yeah.
And so, there is emerging evidence on this that looks good, but really, let's make sure we have that research and evidence that's going to drive this. And not only not political science, but also making sure that it's not just, a profit motive that might be driving what is a very important public health aspect.
That's an interesting way to look at it. And I think one of the things, we've talked about cannabis previously on this podcast, and one of the things about cannabis, and Chris talked about it a little bit, as it's the era of prohibition seems to be coming to an end around the world, led by a few countries and more coming along, and a few states. But there isn't enough science and data. And one of the reasons for that is because it's a legal scheduled substance, you can't study it. So it's interesting to hear you talk about the importance of being led by actual science. Okay, so one more question for me. You've given a couple of good examples of policies that could be better, but if you could wave a magic wand and have 3 or 4 things happen overnight to help address the drug crisis, what would they be? You've talked about, in medical school, you don't learn about addiction. So what are your top 3 or 4 if you could just decide, and it would be so, what would they be to help address the things you've been spending your career working on?
So I'm not going to give the big magic wand answers, because I don't think there is a magic wand answer to this, and I don't want to get myself like tied into things, but I'll tell you 3 things that are really top of mind with me right now. The first is, the eliminating child poverty that leads to trauma. We never think about that as a drug policy issue, as an addiction issue, but it is. And, I think the United States was on a good roll with the child tax credit that lifted children out of poverty. That has been eliminated. It was discontinued. But, having something like the child tax credit that allowed people, and there's research that shows not only did it lift children out of poverty, the parents weren't spending it on, bad things. They were spending it on, the majority were spending it on essential goods, because stress that it accompanies poverty can lead to trauma for children. And we know this. That's one thing that I think is really important. The second piece is when we see, we spend a lot of time on policies to advance treatment in correctional settings, so that because people, when they leave, over 60% of people who enter jails and prisons have either a substance use disorder or a mental health condition, often both. And what happens when they go to jail or prison is that it's not treated. It's usually their condition gets worse. And when they leave jails and prisons, they're overdosing at greater rates than the population at large. We know in the state of Rhode Island, they implemented evidence-based treatment medications for opioid use disorder in their jails and prisons. They reduced overdose deaths in that population by 60% and 66% statewide. So the second piece is medications for opioid use disorder treatment in jails and prisons, and moving people away from incarceration for nonviolent crimes. But really, if they're gonna be there, get them the treatment that they need. And then lastly, I think, is really, we can reduce the stigma that's often attached to addiction, to people with substance use disorder, by recognizing our fellow, citizens, our fellow human beings who have this condition. We start that by, recognizing people in recovery. Recovery Month is September. It's become this really big celebration of people who are in recovery, and again, not whisper about it, but really celebrate people who are in recovery, and they can tell their story and say, this is who I am today. So those are 3 items.
That's fantastic, and sign that we can do something about the problem. I want to maybe throw you a little bit of a curveball. But coming from the fact that fentanyl and opioids do have a legitimate medical use, and we have for a long time had a relationship with Canada where, particularly if you lived in Buffalo or Detroit and you were senior, you had expensive drugs, is you'd go across to Canada, get your prescription filled, and the computer systems allowed that, and then you'd pay less and bring that amount of drugs back home. And for a lot of elderly under financial strain, that was a real lifesaver. Then COVID came and we stopped allowing that. You couldn't just do that as easily. I know this calls for speculation, and any lawyer will say, well, then I won't answer it. But I wonder if we ought to be doing some research now about what happened when we closed the border to that activity, and was there more or less trafficking in some of the negative aspects where people get cheap fentanyl and then they don't need it, but they sell it off to their grandkids or something like that. Like, are there elements we could learn from this episode, which was sort of an experiment we never planned to embark on, that would tell us something about the interaction of the two societies and that sort of back and forth that we do have, and especially with Congress constantly talking about, well, we just want to have Canadian prescription drugs accessible to our seniors because it's a populist issue. I wonder if we could learn a little bit more about that experience and how the transactions at the border go, and whether there was a change when we didn't have access to that.
Yeah, I haven't seen any research like that. I think that would be really interesting to see. I mean, we have a big problem in a couple ways. One is that, people who overdose, we don't have great forensics. I mean, we know that the majority of them have been in touch with a healthcare provider. The forensics that we do have show that there has been an opportunity to intervene. But that, we don't have enough research on kind of the trajectory. And I think that would be really interesting, to look at. You could probably look at New York for that. It might be difficult to identify who has gone across, who was going across, because of privacy rules, kind of, narrowing that universe down, but looking at overdose deaths and seeing what some of the the forensics are on that. That would be really enlightening, I think, because during COVID, we did see an increase in overdose deaths. We saw a decrease in harm reduction facilities being open. We saw an increase in alcohol use. I also think, that we at the time, the increase was also due to the fact there was so much fentanyl in the drug market, and people weren't used to it at that point. So that was also part of it. So there were a lot of opportunities to learn from COVID that I think during that time that I don't think we've looked at yet. That's a great idea.
That's fantastic. I mean, here on Canusa Street, we're very alive to the border, but one of the things that makes the Canada-U.S. border on a good day better than a lot of U.S. border transactions is the fact that it can be cooperative. So maybe it's a place we could do a bit more experimentation. I feel like I've gotten an education from you. I should be paying tuition. This was fantastic, Regina. I really appreciate it. Thank you very much for coming, and I hope you'll come back and talk to us as this issue evolves. It was really an eye-opener for me, so thank you very, very much.
Yeah, I echo the thanks, and not just for joining us, Regina, but thank you for the work that you do. Year after year, decade after decade, it's your work, your advocacy is impacting people on a daily basis, and that's not lost on us, so thank you.
Thank you.
I got a little choked up at the end there, Chris, when I was thanking my friend Regina LaBelle, because she's working on something that a lot of people don't want to think about. I'd rather not think about how many people die of overdose death every day, and it's a huge number. So I'm really grateful to her for the work that she does, and her clear-eyed recommendations. Right? She doesn't pull or punches. So anyway, I thought it was a really interesting conversation.
Me too. I think the late Christopher Hitchens once said it was a 50-50 flip of a coin. Which author had a better view of the future, a more accurate view of the future, George Orwell or Aldous Huxley? And it's hard not to feel that we don't over-medicate in this country, because we don't fund mental health properly. We put people in the position of relying on drugs, and then when the drugs are unavailable, or if they're on them for a long time, they become addicted. There's a lot about both Canada and the United States and our use of pharmaceuticals in our daily lives that deserves a tough examination. And that's not to criminalize it. It's just to say this is a problem. We need to hear about it in a way that we do have frank conversations about alcoholism, about smoking, about other health crises. It's a problem both Canada and the U.S. share, and cooperation should be an easy thing to promote. But it's hard work, so it's not going to be as easy as just waving our wands. The magic wand you offered, Regina, that she swore doesn't exist, and she's probably right.
Yeah, and we think about in other contexts, we think about whole life cycle of things, whether that's carbon emissions or whether it's the circular economy for waste. But Regina pulled back the conversation and talked about early childhood trauma and how that impacts overdose and addiction later. That's not something that had ever dawned on me. And so I think taking the big picture, like zeroing in on the details, but then also stepping back and taking the big picture is really, really useful.
It is. And clearly we've gone through a sea change in this conversation. I sometimes go back to the old Nancy Reagan just say no campaign, which you'll remember, I remember. I mean, well-intentioned, but I think what Regina brought to us, which was great, is a much more sophisticated, nuanced conversation that acknowledges the difficulty, but also the humanity of the people who are suffering, and we should see them as people who are suffering, not as people who are, a burden on society, but people, our fellow humans that we have to help. And I think Canada and the U.S. share that kind of compassion and empathy on our best days, and that is a place where we should bring our relationship and really try to help our fellow people. If we can't do that, what's the point of government? What's the point of Canada-U.S. relations?
That's right. I agree completely. Well, as always, learned something new today, Chris. Thank you so much.
Me too.
Good conversation.
Thank you very much. See you again on Canusa Street.
See you next time.
This podcast is brought to you by the Canadian American Business Council and the Wilson Center. If you like this episode, help others find our show and give us a rating on Apple Podcasts or Spotify.